Welcome to Brain Chat. I'm Dr. Mitzi Joy Williams, your board-certified neurologist and MS specialist, and my mission is to engage, educate, and empower those affected by MS to become an active part of their healthcare team. Here on Brain Chat, we'll be discussing all things MS, health and wellness, advocacy, and we'll even throw a little bit of music and music therapy in there as well. Thank you so much for joining us, and stay tuned for the next episode. All right. Welcome to Brain Chat, everyone. It is Monday. It's a holiday. And although this is a pre-recorded episode, we're really excited to offer a conversation about cognition and MS. So I'm super excited about my guest that I have on tonight, Dr. Sarah Morrow. But as you know, how we do on Brain Chat, drop in the chat where you are logging in from. We thank you so much for taking out your time to learn more about MS and how to advocate for yourself and or your loved ones who are living with this condition. So we are going to talk about cognition, which is a really hot topic in the field of MS, something that we're just now, trying to get a better handle of how to measure and how to make sure we're really addressing in the clinic setting. And so I am super excited to have an amazing expert with me tonight, Dr. Sarah Morrow. So Dr. Morrow is an associate professor in the Department of Clinical Neurological Sciences at Western University in London, Ontario. She is also the director of the London, Ontario MS Clinic. She received her medical degree from the University of Calgary, did residency and training at Western University in neurology, as well as an MS clinical fellowship. She also did a fellowship in cognition in MS with Dr. Ralph Benedict, who's a neuropsychologist at the Jacobs Institute in Buffalo, New York. She also has a Master of Science in epidemiology. In addition to her clinical work, she established the first MS cognitive clinic in Canada, located at Parkwood Institute. And she's in a variety of organizations, including a board member of the Consortium of MS Centers. She also sits on the editorial board of several medical journals, including the International Journal of MS Care. And she sits on a steering committee that I also sit on, MS in the 21st Century. And this is a really cool international collaboration to try to define how MS treatment and standard of care should look in the 21st century. So she is an amazing, well-respected physician and colleague in the MS community and an expert on cognition. Welcome, Dr. Morrow. We're so excited to have you on Brain Chat tonight.
Thank you so much for having me and inviting me.
Absolutely. So cognition is something that, has been kind of elusive to us in the MS community in terms of kind of just really being able to put our hands around and measure on a regular basis with all of the competing demands in clinic and things like that, but certainly something that our patients ask us about and tell us that they're having issues with. So let's start first by me asking you, how did you get interested in this aspect of MS? And then we'll do like a basic definition of what cognition is, so everybody's on the same page.
No, that's a good question. It is an invisible symptom of MS. So it's one, certainly when I was doing my training, no one really talked about. I graduated from my residency in 2007. And back then it was kind of in its infancy of interest, both from a clinical and research point of view, probably more research than clinical.
Yeah.
So I already knew I was interested in multiple sclerosis, and I was thinking about what I wanted to do within that area, and I was already interested in cognition. And that's when I heard about neuropsychologists who are actually doing MS research in cognition in the US, which we didn't have here in Canada. We had people who dabbled in it, but no one who that was their actual research program. And so I started reading more around it, going to more conferences, and that led me to asking if I could do a fellowship in Buffalo with Dr. Benedict, a neuropsychologist whose main focus is multiple sclerosis. So it was a fun adventure because I was the first neurologist to actually do a fellowship with a neuropsychologist.
Wow.
So it's kind of crossing a lot of boundaries and borders, but it was a lot of fun. I learned so much, and I'm really happy to have brought that back to the neurology world from the neuropsychologists.
Absolutely, absolutely. So groundbreaking work there, because that is interesting. So you did your MS fellowship, then you also got a master's degree, and you did an extra fellowship, to focus on cognition. So hopefully this is a model, or an area where people will continue to be able to do extra training, because it's really, really important. So what is cognition, right? So we say you have cognitive dysfunction. What does that mean for a patient or their loved one, who may be dealing with MS?
That's also a really good question because it's in some ways depends on the disease you're looking at.
Mhm.
Most of us in neurology and probably in the general population, when you think of cognition or disorders that affect cognition, you'll think of dementias
Mm,
or Alzheimer's specifically. But really, cognition is everything to do with how you think, how you understand, how you interact with your environment, how you process information, how you remember things, abstract thought, planning. All of that involves cognition, including language, which I don't think I mentioned. So, really, cognition is part of what defines us as humans, makes
yeah.
us somewhat different from other animal species, is our ability to abstract, plan, um, and manipulate information in our brain. And language is another one that's really quite unique to humans. Most of us think of cognition in the, as I said, in the concept of dementia, and it's important to keep in mind that that's very different from what we see in persons with MS. That Alzheimer's and other dementias tend to affect language, so people will not know what the name of something is,
Mhm.
or they won't remember someone's name, or they might have what we call apraxias. So
Mhm.
that's the ability to manipulate objects and know what they are. So that would be like knowing how to use a knife and fork or knowing how to do up buttons. And agnosias, where it's you don't remember who people are.
Mm.
Whereas with MS, it doesn't affect language, which is really important. And it also doesn't affect general intelligence. So I always tell my MS patients, you're still the same as person you were before. It's just MS may have affected some aspects of your memory and thinking. Specifically with people with MS, it tends to affect more that processing of information, that ability
Mhm.
to get in that information and use it quickly, or the opposite, take it and bring it to the forefront of what you're thinking of, as well as kind of that episodic memory. So it's not that you don't remember who someone is, but you're just like, what's their name? I know I should know their name. I haven't seen them in 2 weeks, or I haven't seen their daughter in a few weeks and I can't remember their name either. So it's that remembering kind of those episodes in your life in the past as opposed to completely forgetting things. Similarly, it's that with the language, it's not that you don't know what a fridge is or what a fridge does, but you might be like, "Oh, can you go get me something out of that thing that keeps things cold?"
Right.
Where there's also a freezer. What's that thing called? And someone will say the fridge, and like, of course, it's the fridge. So it's kind of a different presentation than you'll tend to see in people who have dementia or Alzheimer's.
Mhm. Yeah, so I love so many things that you said, and so many of the things that you described are things that people often come to the clinic and say, "Hey, Dr. Mitzi, I'm having trouble with that." So, in thinking about the symptoms of cognitive dysfunction, you mentioned several things there. You mentioned something that I tend to call word finding difficulty, right? So, you've got that word on the tip of your tongue and you just can't get it out, that happens to me sometimes, but not as frequently as my MS patients. And I say, you know what, in the middle of the night, I'm going to wake up and that word's going to come to me. But my patients have a lot more difficulty with that. You also mentioned slowed processing. So, not being able to, grasp that information. Sometimes they may have to read it 3 or 4 times to kind of get it to sink in. What are some other symptoms of cognitive dysfunction or ways that someone can know, you know, I'm having a little bit of difficulty with my cognitive dysfunction. And the reason I think that's really important is because I have a lot of people that come in and say, "Oh, well, I'm getting old." And I'm like, "Well, you're 25. You shouldn't be having memory difficulty at 25." So a lot of times people will chalk it up to, "Oh, I'm getting old," or "I'm just tired," but it really could be related to their MS. So how do people know kind of what some of those core symptoms are and when to be asking for help?
There's so many important parts of that question, Mitzi. Um,
Mhm.
First, I'm happy to hear that your patients are bringing up to you because I think that's one of the areas that we as clinicians are not being, um, we're not teaching our patients to ask us about cognition enough.
Right.
In that as you said, they'll chalk it up to I'm getting old. Although if 25 is old, we're all in trouble. Um,
Right.
or I've got a busy life, or I've got young kids, or work is really busy, or juggling kids and work and deadlines and a husband. There's just so many things that you can blame it on. So I'm happy they're bringing it up to you. Um, but you're right. A lot of what is happening, you can also see with aging, and you can see
Mhm.
in real life. And a lot of my patients will say to me, well, I talked to my husband about it, and he said, well, I do that too, but I just do it more than him.
Right.
Or this is not my normal. This is not, I'm usually good at this. I'm someone who can manipulate data in my head, and now I'm not able to do it. So a lot of it has to do with exploring how it's having an impact on their life, because that's the best way to see if it really is something real. Not that it's not real, because of
Mhm.
course what they're experiencing is 100% real, but is it an impairment versus just normal life or due to something else? um,
Right.
as well as kind of walking through the impact it's having and how they may have had to make changes to accommodate it.
Mm.
So, for instance, if they're double checking their work, but never making any mistakes, but never remembering if they did it properly, and that's new for them, that's an issue.
Right.
So it's a little more pathological than just, oh, did I do that because I'm really busy? Or that one of my patients couldn't remember if he turned off the coffee when he left the house in the morning. So he'd remember he just unplug it from the wall, so he didn't have to worry about did I actually turn it off or not. Or forgetting about deadlines, having to set yourself more reminders on your calendar than you normally would. So it's all things that are normal, and that's the thing, is it's all, they have normal intelligence, they have normal language, they have normal memory, they remember things from their childhood. It's just, it's interfering with their life more than it should. And
Mhm.
for me, just opening up that discussion so that they can bring it to you and you can say, okay, that sounds like you're struggling more. Maybe it's something more to do with your MS versus, you know what, it also just could be because you're not getting enough sleep, or you're fatigued, or
Right.
you have too much going on. You're doing the job of two people, which has happened a lot during COVID, that people have
Right.
taken a lot more responsibility. So the unfortunate thing is there's not any one symptom you can say, you can hang on to and say that's the problem,
Mhm.
but it's more a constellation and how it's impacting their day-to-day life that for me it signals to me that I should be more concerned.
Yeah, and so we had an episode last week where we really talked about shared decision making. We talked about patient empowerment. And one of the things that we really discussed at length was kind of keeping track of what's going on with you in between those visits, so you can make the most of those visits with your neurologist. Um, and I think that this is a really key point, that you're bringing up. How do you have to accommodate, right? So, oftentimes people will kind of blow off certain symptoms and say, oh, it's nothing, but I think that it's important to keep track of the things that are going on if you're having to make accommodations. And then also, as you mentioned, that family member, right? Those other people around you can really be an important piece, because sometimes you don't know what you don't know, right? And so sometimes that care partner, that best friend, or that spouse, or that child will be the one that comes in and says, I told mom, or I told my wife this, 20 times, and it was like I never told her, right? And so having all of those perspectives is extremely important to help us to really get a good idea of what's going on with you. But this is something extremely important that I think people need to talk about more commonly. And I think it's also important because many times in the past with cognitive dysfunction, we can't really figure out that it's going on until the cat's out of the bag, right? Until we're having to make significant accommodations at work, or put people out on disability, or they're getting ready to lose their jobs, right? We want to try to get ahead of it to see what adjustments we need to make to treatment regimens, et cetera, so that we don't get it, on the tail end when it's happening. There is something else that you mentioned that I also think is important, that there are other symptoms or other things that can contribute to cognitive dysfunction. So, some of the other things I always talk to people when they tell me they're having trouble thinking, about sleep, about medications. Let's talk a little bit about what other things can contribute to cognitive dysfunction aside from just MS itself.
And that can get a bit complicated because, in some ways, the research is not fully elucidated in the MS population. So, a lot of
Mm,
what we're doing is extrapolating from other diseases or from
mhm.
people who don't have MS.
Right.
So, for example, mood, depression,
Mm,
and anxiety both makes people subjectively feel like their cognition is not up to snuff,
Hmm.
and also can objectively affect cognitive testing. So
Right.
that's really important. So people without MS who have depression and anxiety will have those subjective feelings as well as those objective findings if you actually do their testing.
Hmm.
So we always consider that, especially because it's something that's more treatable. So
Right.
we haven't got to it, but the treatment for MS cognitive impairment is still early in the stages of development. So,
Very
you know,
early.
finding other things that you can address is really important. Fatigue, no matter what you do, I mean, anyone who's had a young baby who's breastfeeding will know that when you can't think straight the next day when you've been up all night, or anyone who's a physician and has done call and you're the
Right.
next day you can't put two and two together. So that's going to affect your cognition, at least subjectively. The data is mixed in terms of whether that truly affects the objective testing, but it certainly makes you feel like you're not cognitively doing well. Poor sleep, which can lead to fatigue. We know sleep apnea can make people cognitively impaired. So, of course,
Hmm.
if people are not sleeping well or have sleep apnea, that's going to affect it as well. And then, as you mentioned, medications. So, anticholinergic medications. We did a small study, but it was pretty clear that patients who were taking anticholinergics for bladder symptoms had a
Hmm.
worsening in their cognition compared to those who did not. So,
Hmm.
you have to think about what other medications could be affecting it as well. So, you don't want to just hone in on MS being the cause.
Right.
But on the flip side, as you said, I also don't want people to dismiss MS as being the cause.
Right.
We can't just think of someone with MS as having MS, or someone with MS as just having, or someone with cognitive impairment just having cognitive impairment. That we have to think of the whole person,
The whole
similar to what
thing.
you were saying, holistic approach earlier is
Yeah.
you need to think of all parts of that person's life and medical life and how that might be affecting their function day to day.
Right. And so this is really an important piece of holistic care and individualized treatment, right? The goal is we look at that patient, the things they have going on, and try to come up with the best treatment plan in conjunction with them for that person. And so the way I often describe it to my patients is, let's say you've got cognitive dysfunction. We know you've got lesions of your brain, right? Let's say this much is from the MS. Okay. And then we have significant fatigue, right? You're sleeping 2, 3 hours a night. Okay. That makes it this big of a problem. Okay. Then on top of that, you've got spasticity, you've got some other issue. I'm giving you some medicine that makes you more fatigued, right? And that makes it this big. And then on top of that, let's say we're having some depression. That makes it this big of a problem, right? And so maybe this much is from, let's say, lesions or MS itself, but these other things make it really, really interfere with your daily activities. And these other things are potentially treatable. So we have to figure out kind of how we can address these other issues, and there's not always a clear cut answer. I tell everyone, I wish I could draw you a circle and say 50% is your MS and then 10% is this problem and draw you a little pie chart. And, but it's not always that simple. And so sometimes things are, kind of going all together, but we try to see other causes that may be more treatable, and address those so we can really get an idea of what that baseline is. And what about when in the course of MS can cognitive dysfunction occur? Can it occur early? Is it late, or is it in the middle? Should people when could it happen?
So the answer to that question is yes.
Yes.
It can really happen at any time. So
Right.
um, there have been recent studies that have shown it can be seen as early as clinically isolated syndrome, which is
Wow.
that first episode of neurological symptoms
Mhm.
before you actually meet the diagnostic criteria for MS. So kind of that
Mhm.
first episode of MS where it's not
Right.
proven to be a chronic disease yet.
Right.
There's actually even some interesting studies looking at that condition we've termed radiologically isolated syndrome.
Mhm.
So, for your listeners, that's when someone doesn't have symptoms of MS, but gets an MRI for another reason, maybe headaches, maybe you're a study participant. That's I've seen that a few times. Um,
Mhm.
Car accidents, other things. You get an MRI, and suddenly you see these lesions on the brain that look like MS lesions, but they've never had any symptoms. So
Right.
is isolated to the MRI, so radiologically isolated syndrome. And
Right.
we've seen cognition can be impaired in up to one third of those samples.
Wow.
Now,
Wow.
that's a bit of a bias sample in that it's not a true population study, right? So it's not, we're not saying that a third of patients with those lesions have cognitive impairment because we're only seeing the small ones who are actually getting an MRI
Right.
coming to clinical attention. So
Right.
clearly something was going on to bring them to medical attention in the first place. So
Right.
that may be an overestimate, but it's showing how early it happens.
Mhm.
But just like everything else in MS, no two people with MS have the same disease. I tell
Right.
my patients, you guys are unique. No one is going to have the same MS as you. So it may be that some people cognitive impairment doesn't really occur at
Hmm.
all, or if it does, it's so mild that they don't really notice it, or it's not interfering with their function. Whereas others,
Right.
it may be that they're, physically you wouldn't know there's anything going on, that they have MS, and yet they're quite cognitively impaired, and it's
Mhm.
interfering with their life, their ability to work, their ability to talk to their family, interact with people. So it can be at any stage of the disease, both the
Mhm.
relapsing phase, the progressive phase. It can be associated with progression, it can be associated with relapses. So
Right.
it's really something that needs to be addressed at all stages of the disease, just
Right.
like any other symptom. We wouldn't
Right.
say, oh, you don't get bladder symptoms till you've had disease for 10 years. It could be a presenting symptom for some. We just have to
Right.
think of cognition the same way.
Yeah, yeah, I love that response. And I think that's important because people need to know that this can occur at any point in the course of their MS, and that again, it's something you can bring up at every visit. Just like we talk about disease modifying therapy, how's your cognition? How's your thinking? Are you having more trouble at work? Are you having more trouble doing your tasks at home or doing things that you used to be able to do? So again, this is a part of overall health, and in that vein, how do we measure cognitive dysfunction? So, certainly, we take a history when people come to see us, but obviously, cognition is sometimes not something that we can see very easily, right? So, we have a very minimal test that we can do in the clinic, where we do kind of a very baseline cognitive assessment as part of a neurologic exam. But for people who are very high functioning, oftentimes they scored almost perfect scores on those, right? So let's say if you're, very high functioning, working in a professional setting or some other type of setting where you're having to multitask, our little simple testing, you may pass with flying colors, but people will say, I know that something is wrong and I know that something is different. So, how do we measure cognitive dysfunction?
So before I kind of go into the tests, I think you hit the nail on the head there, is that monitoring for change over time, just like you would with any other symptom of MS, is important. So, you're testing for tone, you're testing vision, you're testing reflexes, you're
Hmm.
testing strength. You're asking about bladder and bowel. You should be also thinking about cognition, whether it's an objective or a subjective assessment at that time. One of the things we've done in our clinic, although we do have of course, luck of having our MS cognitive clinic where we have this available to us, is we've started doing cognitive testing on all MS patients when they're first diagnosed.
Hmm.
Because I was encountering what you just described, is I'd be seeing people who were VPs of companies or PhDs, and they're saying, I'm not as good as I used to be. And I do their testing and say, well, you're normal, because of course you standardize the scores and compare them to the normal population. So they're normal, but they're not their normal. So
Right.
having something you can monitor over time really makes a difference. So getting something as soon as you can, maybe not a
Hmm.
right diagnosis depending on what's going on, but getting it in as soon as you can, and then being able to monitor for change over time. And I explain it to my patients kind of like an MRI. So,
Hmm.
if I want to know what's new on your MRI, I got to know what's there now.
Right.
So if I get one now, we've just started a new treatment or we've switched treatment, we're going to get a baseline MRI. And then in a year, I can do another MRI and say, this is new, I'm concerned, or there's nothing new, I'm not. So I kind of approach cognition the same way.
Hmm.
It would be most beneficial to have a validated screening measure. Having said that, I do realize that it can be a bit daunting to incorporate that into a clinic.
Hmm.
So often, as long as it's something that's done the same way every time,
Hmm.
that you can monitor change over time, I think that's the most important thing.
Yeah.
So the test I like the best is the symbol digit modalities test,
Hmm.
simply because it measures processing speed,
Hmm.
and that's the most commonly affected area in MS, as you said, that tip of the tongue where they can't come up with the right word, or can't process the information to remember it, or process the information to bring it back.
Hmm.
Um, Although that is missing a lot of other aspects of cognition, it's a nice screening test that's been validated. And it
Mhm.
takes about 90 seconds. It takes 90 seconds to do the test, but if you consider all the setup and everything, it takes less than 5 minutes. So it doesn't add a
Mhm.
lot once you're proficient at it.
Mhm.
If you have more time, adding in measures of memory, I think is really important.
Mhm.
There are some iPad versions. So sometimes if you've got a busy clinic, there's iPad versions of the
Mhm.
STMT,
Mhm.
doing them, and you can get the patients to do it in the waiting room as long as it's quiet. You don't want them to have
Mhm.
distractions. Or
Right.
sitting in the room while they're waiting for you to come in, they can
Mhm.
just do their quick iPad test. But as long as you're doing the same thing over time,
Mhm.
I think that's the most valid measure. Just like anything else, you want to be able to compare change over time. The
Mhm.
one thing I would say is avoid using tests like the MMSE or the
Mhm.
MoCA, because those
Right.
are really geared towards dementias,
Right.
and you're not going to get change. You're not going to be able to notice in cognitive impairment until it's quite obvious.
Right.
And also, you're not going to be able to get that measure of change because
Right.
both those tests have things like orientation. So do you know what
Mm.
year it is? Our patients know what year it is.
Right.
They have an easy naming. So they're low
Right.
frequency words, but our patients know what a camel is. They just might have trouble getting it to the tip of their tongue.
Right.
So those tests, I would say, avoid using the tests that are really geared towards dementia.
Yeah.
The other is you want to do it too frequently because you get better at doing tests just by doing them. So, I always say I got really good at multiple choice in high school, not because I necessarily knew more or studied better, but because you get to learn the technique of multiple choice questions.
Right.
So it's the same with these cognitive tests we use. So if you're using similar tests, you will get better at it just by the practice effect that you see.
Mhm.
So maybe doing it every 2 to 3 years, maybe
Mhm.
just addressing it in clinic, but then doing the objective test every 2 to 3 years, or
Mhm.
when there's a change, like with an
Right.
MRI,
Right.
starting a new treatment, you're starting a new job. Maybe now is the time. Let's do that quick 90-second test just to see how things are so we have a good baseline going forward.
Yeah, I love that. So I incorporated some electronic testing that we can do at certain intervals with a company, so the patients can do it at home in the quiet setting. We do it like once a year, so we can kind of get an idea what their baseline is, and then measure how they may change over time. But I think that's really important. And I think that, as neurologists, there are some of us that are doing our best to try to fit it in, but I think we still have a way to go in terms of really making this something that we, really measure in real time on a regular basis, to help our patients. So, in that vein, and talking about helping our patients, how do we treat cognitive dysfunction? Is there a treatment for cognitive dysfunction, or are there treatments?
So the short answer is no.
Right.
But the long answer is sort of, and
Sort of.
I'll tell you a bit about it. So,
Okay.
um, there are some cognitive behavioral techniques, some
Hmm.
interventions, some rehabilitation interventions that are available. Unfortunately, here in Canada, we don't have access to them because of payments. So we are socialized medicine, but that covers medical visits. It
Hmm.
doesn't necessarily cover things like counseling and other psychological interventions. So
Hmm.
in the States, I know they're used much more often with
Hmm.
a lot of success. The Kessler Group has
Hmm.
done quite a bit of work looking at interventions that are helpful,
Hmm.
and they are. The other is that there's more and more evidence showing that disease modifying therapies likely have some impact on preventing cognitive impairment,
Mhm.
although we don't think that they themselves may affect cognition. But if we think that atrophy or shrinkage of the brain
Mhm.
is correlated with cognitive impairment, which we know it is,
Mhm.
and that relapses can affect cognition,
Mhm.
and we know disease modifying therapies prevent those
Mhm.
or minimize those,
Right.
then kind of, if you connect the dots, you can say that we are likely also helping cognition or helping preserve cognition.
Mhm.
There's also some studies ongoing with amphetamine products.
Mhm.
So we're doing a study right now with Adderall XR, the long-acting version of Adderall, simply
Mhm.
because it's better tolerated.
Yeah.
I always say my patients don't want to get high; they just want to think normally.
Right.
So they don't like the short-acting ones.
No, because they go up and then they go
They
down.
crash, exactly. Whereas the long-acting ones are better tolerated, and we're getting some early signals that it may be beneficial, but we're still in the early stages. It's sponsored by the MS Society of Canada, so
Mhm.
stay tuned for that. Hopefully, in the next year or so.
Okay,
Um,
awesome.
And then there's some studies that show that Vampira may be beneficial in certain circumstances. The
Mhm.
the data has been mixed, but there was one relatively well done study that showed that it was beneficial, although other studies have shown it wasn't.
Mhm.
But similar to what you were saying before with treating depression or other mood symptoms or fatigue, if they if their Vampira is going to help them with their mobility, and it also helps with their MS, is kind of a bonus.
Right.
The mainstay, I'd say, of what my treatment is counseling. So I'd say number
Mhm.
one is even just saying you're not crazy. It's your MS that's causing it. I
Right.
think sometimes because it's an invisible symptom, they feel as if there's something wrong with them. And so
Right.
saying, no, there's nothing wrong. It's your MS, and validating that what they're feeling is real, and
Absolutely.
validating that what they're feeling is not to do with who they are as a person.
Mhm.
And then the next we do is we do a lot of behavioral techniques. So
Yes.
pacing,
Mhm.
making lists,
Mhm.
setting reminders on the phone, little things like if you're not good at processing information, having people send you a text or an email with the things you need to do the next day so that you don't have to remember on the spot. Um, it's easy. It's interesting to see how quickly you can kind of train those around you. Not really
Mhm.
training, but if you say it often enough, great, send me an email. People will learn that you just want an email with that
Right.
information. It'll happen.
Right.
Technology, as you were saying before, we've really accelerated our use of technology, especially during the COVID-19 pandemic. So
Mhm.
using technology to our advantage, have a shared calendar with the family. So when your kid says, I have a soccer practice at 7 o'clock on Monday, you can say, great, put it on the calendar. And then it's sent right to your calendar and you don't even have to remember it. It'll be right
Right.
there and the alarm will go off and tell you what you need to do. So
Right.
using that to your advantage. There's a lot of
Mhm.
other things, but we try to, of course, tailor it to what that person themselves are experiencing. But a lot of it
Right.
is kind of just changing how you interact with other people and how you interact with your environment, and
Mhm.
then getting other people to change how they interact with you as well, which sounds more daunting than it actually is. It's a
Right.
little more easy to do than people think.
I think so. So I, always talk to people again about behavioral modification, lifestyle modification, right? So what can we use or what tools do we have available to help us to function optimally? I always tell people smartphones are smart for a reason. You can keep voice memos. If you don't want to write it down or type it, you can record it, but those things are extremely important to help you to kind of accommodate so that you can at least overcome some of the challenges of cognitive dysfunction. Also, making sure that we address those other issues, right? If we have insomnia, that may be contributing, making sure that we're treating that or dealing with other symptoms like fatigue, all of those things are extremely important. And when you said counseling for patients, but I also very strongly recommend counseling for their family members because sometimes people don't recognize. So, just like we know it's a silent symptom of MS, sometimes family members or care partners don't recognize it as a symptom. So, I've not uncommonly had someone come in and say, she's ignoring me, or maybe that person, is just not doing what they're supposed to do. And it really is cognitive dysfunction. So we have to make
Mm-hmm.
sure that people are aware this is a real symptom of MS. They're not purposefully ignoring you when you tell
Mm-hmm.
them something. They really may not be able to remember, or
Yeah.
process what you told them. And so
Yeah.
I think that often is very helpful, in, improving their environment as well as in facilitating that conversation about, having people adjust to better ways to
Mm-hmm.
communicate with you, so that you can get the things done you need to get done. But yeah, those are
Absolutely.
some amazing, amazing tools.
One of my favorite lines
Uh-huh.
is exactly what you're saying. When someone doesn't understand, is I say, if you were in a wheelchair or used a cane, no one would expect you to take the stairs.
Right.
You would take the elevator. So why can't we take the elevator for your cognition? We just have to
I love
explain to
that.
other people
Yeah.
that why you need that elevator, because they can't see the cane and they can't see the wheelchair for their
Right.
cognition. So it's just a matter of educating the family and friends around them so that they would give you the same courtesy that they would if it was a physical impairment.
Yeah, I love that. I love that analogy. So I'm going to give you credit the first time I use it, and then I'm going to steal it. So just
Steal
so you know.
away, steal away.
Okay, so a couple more things. I know we're coming to the end of our time, but tell us a little bit about your MS cognition clinic. So what goes on in that clinic, or how do you address cognitive function in that setting?
Yeah, it's a pretty fun clinic. It's probably my favorite clinic that I have because, of course, I have a regular MS clinic like we all do, those of us who work in MS, and then this is a clinic that is dedicated to cognition and
Mhm.
cognitive impairment. So it's a long visit. So patients will come in and they'll do an interview with me first, and we'll kind of explore in more detail because, of course, in a regular MS clinic, it's busy. There's a lot going on. You might be dealing with side effects of medications or dealing with asbestos, as you mentioned, or all sorts of other things. This gives us a good half an hour or more, depending on how much we have to talk about, where we really dig into how is cognition affecting your life. And
Mhm.
sometimes they say, oh, it's not a problem at home, and then you dig in and you say, "Well, is it?" And they're like, oh, and they find some other things where it is perhaps
Right.
manifesting at home.
Right.
Or someone's commented that you never remember what I told you. It's like you don't care about my soccer or whatever it may be. So we really dig into it. And then we also talk about all those other things, which you mentioned before, that could be going on, like depression and sleep and other medications. We really delve into what else might be going on. One of the things we do talk about a lot is cannabis use, because,
Mhm.
of course, cannabis is legalized in Canada, in some states
Mhm.
in the US as well, but it's
Right.
legalized in Canada.
Mhm.
So there certainly is a large proportion of our MS patients who use it. So educating them about the use of cannabis and the effects it can have on cognition.
Mhm.
I think of it as any other drug. So you just need to think about it in moderation and take the side effects and the benefits that you note and decide whether you want to use it or not, or how
Right.
much.
Right.
And then after that, they go and they spend some quality time with my psychometrist.
Mhm.
It can be about an hour and a half, or it can be all the way to 2.5 hours, depending on how things go. My
Mhm.
psychometrist is very experienced working with MS patients. We've been working together since 2011 now, and so
Wow.
she knows that often MS patients need bathroom breaks or fatigue,
Mhm.
or if
Mhm.
it's hot, might need to cool down before going on with the testing. So kind of
Mhm.
pacing it so that we're not stressing them out too much, although albeit most of them do find it stressful, unfortunately.
Mhm.
So we try to test all cognitive domains. And as we were saying earlier, no two people with MS are the same. So no one's going to have the same pattern of issues. So we do the MAC-FIMS battery, which is a validated measure of cognitive impairment MS, which
Mhm.
covers processing speed, memory, um, executive function, visual spatial ability, verbal fluency. And then we throw in some other additions like mood symptoms, sleep
Mhm.
symptoms, fatigue, pathological laughing and crying, because that can be associated with
Right.
cognition. We look at self-reported, because it's important for us to kind of get a sense of what they're noticing in terms of their cognition, so we can compare the two.
Mhm.
Um, and then we sometimes throw in some fun tests if we're trying to validate new tests and see if they're working well, or see if patients
Mhm.
actually like them.
Mhm.
Um, so then it ends up being a mixture of validated objective tests as well as subjective self-reported tests.
Mhm.
And we've also thrown in some personality testing, because I'm kind of interested in the personality of MS,
Mhm.
um, just for fun,
Yeah.
for me more than anything.
Yeah.
And then we don't do a follow-up that day, just because by the time they're done, they're pretty tired.
They're pooped.
Yeah, exactly. And we also want them to have a family member with them. I
Yeah.
find a lot of them come without a family member, and that certainly increased during COVID. So if we need someone, we'll often call them on the phone just to get
Mhm.
part of the history if I feel like we might be missing something. But
Mhm.
then we do the follow up, and I've been doing that virtually these days. It makes it easier for the patient, and
Mhm.
also easier to have a caregiver there, as you said.
Yeah.
I like to always make sure that when we talk to them, that if it's not their spouse, that it's a close family member, maybe
Mhm.
a parent or a sibling,
Mhm.
or a close friend, someone who can
Mhm.
understand. And if they mention someone specifically that's noticed their issues or perhaps is getting frustrated with their issues, I'll often mention that maybe that person should be the one on the
The one
phone.
that
And
should come. Mhm.
yeah, and then we just going through it, always asking how they feel, what they noticed with the testing, and then going through the testing, going through the results, talking about what it means, talking about how it explains what they're noticing, validating what they're noticing, and then going into how can we help? What can we
Right.
do?
Right.
And uh, that probably takes another half an hour follow up. A little shorter over virtual
Mhm.
now, but still,
Mhm.
it takes a lot of talking. Often, I have their family member writing things down, because, of course,
Yeah.
that's a problem. So it's
Yeah.
nice to have someone else to document what we're talking about.
Mhm.
And then if we have trials that they could be a part of, or in your interventions specifically that we think are available to them, we'll
Mhm.
talk about that. And then the final is, how do we want to follow up on this? Is
Yeah.
this something you want, this full test, which was a half a day of your life,
Mhm.
in 2 to 3 years? Or do you want to wait until either you, your spouse, or your neurologist says, it's time to do that again? Because we
Mhm.
do that little screening in clinic. So, we're
Yeah.
getting a little idea, but when do you want to do the whole testing? So
Mhm.
that's kind of a day in the life of one patient going through the
Yeah.
clinic.
Yeah.
It's a lot. I
Mhm.
will say it is a lot for them, but we try to make it as simple as possible, and
Mhm.
explain to them, this isn't about intelligence. Some of the tests are timed. It's okay if you get lost, jump right back in. If you
Mhm.
need breaks, let us know. We
Mhm.
know that you have MS. That's why you're here, so that we can
Right.
try and accommodate them and make them as comfortable as they can during the testing.
Yeah. I love it, and it's so needed. I mean, I wish I could just transplant my folks to Canada to come to Cognitive Clinic and, but it's definitely needed. And I absolutely applaud the work that you're doing. It's so important, to really help the overall lives of our patients with MS, so we have come a long way with our disease modifying therapies. We know they can prevent things, but we really want to make sure that people are functioning on a daily basis to the best of their ability. I want you working. I want you taking care of those kids. I want you doing everything you're big and bad enough to do. And so this is an extremely important piece that we definitely need folks, like you working on. So we always end brain chat, ask, giving people tips on how to be empowered. I think empowerment is extremely important, because with symptoms like cognition, sometimes it can feel a little depressing, like, oh my God, like this is going to go and there's nothing I can do about it. So what can people do to, let's say, protect their brains if there's anything, we talk a lot about brain health, or what can they do to deal with these symptoms, or how can they help themselves?
So there's probably two different things, really, in
Yeah.
that,
Yeah.
you know, um, use or lose it's a real thing. We say that in other things. So cognitive reserve, which is that, building up of reserve of what we don't exactly fully understand how it happens, but
Hmm.
those who have more cognitively demanding jobs or cognitively demanding leisure activities, or higher levels of education as just a marker of cognitive reserve, we know that they are more protected against cognitive changes over time. So
Hmm.
despite perhaps the same amount of atrophy or brain shrinkage, they may not show that same cognitive change. So I always encourage patients to use their brain just like you would anything else.
Right.
So doing things that they both like to do, but some things that they find more challenging. So if they're really good at crosswords, then don't just do crosswords. Do some, uh, numbers like Sudoku or something else. So
Hmm.
something that's a
Hmm.
little bit more challenging, because
Right.
I always say, if you only ever, do a curl with your right bicep, you're just going to make that bicep bigger and you're not going to get healthier. You're not getting
Right.
stronger. So it's the
Right.
same idea with your thinking is read. If you don't like novels, that's fine. Read the newspaper, listen to podcasts, all those things that make you think about and
Hmm.
use your brain in different ways, but not too much, in the sense that I don't want them doing things that they find stressful. Just, I don't want to be like more homework, like, oh, I have to do
Now
that
I have to
crossword.
go
I
do
know I have to
pen
go. Yeah.
puzzles because Dr. Morrow said it's
Yeah,
gonna help my
exactly.
brain. It's
But mix
stressing
it
me out.
in. But mix it in. Mix it in with some of the things you're doing, but make sure that you are active. Just
Yeah.
like we say, keep active physically, keep active cognitively.
Yeah.
There's also some evidence that physical activity likely protects against cognitive impairment. So
Hmm.
there's lots of evidence that shows that people who have MS and other health issues do worse, and that applies to cognition as well. So looking
Mm.
after your overall health is really important. And then um, treatments for MS. So as I said before, we know disease modifying therapies reduce atrophy, reduce inflammation. So by definition, that's likely going to also improve your cognition, or at least preserve your cognition, which is really a lot of what our DMTs are doing.
Yeah.
So being an advocate on health in that way. And then little ways to advocate for yourself in clinic is, it's hard, but don't be embarrassed. It's easy to say, it might be harder to do, but there's nothing wrong. They haven't done anything wrong. It's not like they did anything wrong to get MS,
Right.
just like they didn't do anything to get cognitive impairment.
Right.
So being able to bring it up and talk about it and say, I can't do something in the afternoon because my fatigue is too bad. I need to do my cognitively demanding tasks in the morning when I'm fresh. Do it. making lists when you go to your appointment, having a list
Yeah.
so you know, I want to talk about X, Y, and Z, so you don't have to worry about forgetting it when you get there.
Yeah.
And using the tools around you so that you talk to your family, you talk to your friends, you talk to your work. We're here to support you as your clinicians. I don't want you coming to me after you've had a reprimand at work or after your hours have been reduced. I want to be in there early so that we can make
Right.
accommodations and keep you working and doing
Yeah.
everything you want to do.
Yeah.
So I think that way preparation really helps, because then
Hmm.
how you can talk about it with your neurologist and your family.
Yeah, absolutely. And you've said so much that I think is so valuable to our audience, to people living with MS, to their care partners. And I think, it definitely boils down to a couple of things: taking care of your physical health and keeping track of what's going on with you, bringing that up at your neurologist visit. Be empowered to know that this is important. It's something you can talk about. It's not something to just kind of, push to the side. But we're here to partner and help you to come up with those solutions that can help you get, through your workday, be able to accomplish the things that you want to accomplish with MS. So thank you so much for your time, for your valuable, valuable knowledge and advice. I am sure our audience has learned so much from what you've talked to us about, and we're so excited to see what new studies will be coming out of the work that you're doing, and really appreciate all you do to help the MS community. And with that being said, we will sign off for Brain Chat. I will see everyone in 2 weeks. Thank you so much to our sponsors, Janssen, Biogen, and Genentech, and thank you so much to blackdoctor.org for sponsoring this great program. Have a wonderful evening, everyone, and we will see you soon. Thank you so much, Dr. Morrow.
Thank you.
All right. Have a great night, everyone.